So now we'll move on to stomach pathology. So in stomach, we'll see about gastritis first. So gastritis is nothing but inflammation of the gastric mucosa. So it can be classified into acute gastritis and chronic gastritis. Acute, we all must have probably experienced mostly. So usually when people have some fever, they tend to gulp down a paracetamol. So paracetamol is an NSAID. So NSAID drugs, they are actually inhibitors of prostaglandins. So prostaglandin is a very essential molecule for gastric protection. So prostaglandins will induce the formation of the mucus barrier in the stomach. So stomach is known for producing gastric acid, which is HCl. So this HCl is going to be a corrosive material. In order to protect the stomach from this corrosive HCl, the stomach is having a protective lining. So that mucus barrier is going to be there, which is going to be contributed mainly by the bicarbonate, mucus cells, and also by the prostaglandins. So these prostaglandins, which are protective in the stomach, are going to be inhibited by the NSAID drugs. So whenever NSAID drugs are being taken, this mucus is not going to be formed, and the acid can directly act on the gastric mucosa, and that is going to cause the irritation of the gastric mucosa and inflammation. So that is why we always advise to put pantoprazole along with NSAIDs, so that this protective layer is still there. Okay. So drugs like NSAIDs and also even stress. So during exam times also people must have felt gastritis episodes. So that can also trigger acute gastritis. So in stress, we have two special conditions called as Curling's ulcer and Cushing's ulcer. So in burns patient, these patients specifically develop these Curling's ulcer, which are going to be superficial in location, and mostly they are in a duodenal location also. Okay, in a duodenal location, these patients are developing superficial ulcers in burns patient, which is called as Curling's ulcer. While in intracranial increased pressure conditions like a meningitis, so in those conditions or some intracranial space occupying lesion is there, that is going to increase the intracranial pressure. So in those patients, they are going to develop deep ulcers in the stomach. So stomach deep ulcers are seen, and these are called as Cushing's ulcer. So we all know Cushing's syndrome also, right? So remember, Cushing's is related with increased intracranial pressure, and since Cushing's has an S, it has to be present on the stomach. So stomach deep Cushing's ulcer seen in increased intracranial pressure. Then moving on to chronic gastritis. So when there are repeated episodes of this acute gastritis, it can progress on to a chronic gastritis. Chronic gastritis, again, we divide it into two things, which is type A and type B. So type A is going to be caused by an autoimmune condition. So A for A. Remember, type A for A, that is autoimmune. So in this autoimmune condition, there are going to be formation of autoantibodies against the parietal epithelial cells. So in the gastric lining, we have parietal epithelial cells, which are responsible for producing the intrinsic factor and HCl. So when antibodies are acting against these parietal epithelial cells are going to be lost. So it will result in decreased HCl production and again decreased intrinsic factor production. So when HCl is being decreased, the gastrin, which is a stimulant for HCl production, it will have a reflex gastrin. So increased amounts of gastrin will be produced. Okay, it will try to trigger the formation of gastric acid. So decreased HCl will have a compensatory reflex, increased gastrin, and intrinsic factor is being reduced. So we all know intrinsic factor is a factor which is needed for absorption of vitamin B12. So without intrinsic factor, B12 will not be absorbed. It will lead to megaloblastic anemia only. And in this condition, that is this autoimmune condition wherein it is due to the intrinsic factor deficiency, this megaloblastic anemia is going to be called as pernicious anemia. Okay, pernicious anemia is vitamin B12 deficiency caused due to autoantibodies to the parietal cells. Then in type B, gastritis, chronic gastritis, it is going to be caused by a bacteria named as H. pylori. So B for B, bacteria H. pylori. So B for B. So this H. pylori is the most common cause for chronic gastritis, and most of the patients usually have H. pylori in their stomach. So it is a non-invasive bacteria basically, but it is going to be a chronic condition. So in order to eliminate that, you'll have to give some antibiotic course. Okay. So H. pylori, it will actually produce the increased amounts of HCl. So there will be reflex decreased gastrin. So it is the exact opposite of autoimmune condition. So remember H for H. So HCl will be elevated in H. pylori infections. And also the location of these gastritis based on the cause is also going to be different. H. pylori, it is always an antral location. So antrum, you can see this gastritis. So antral gastritis is going to be caused by H. pylori, while autoimmune gastritis is going to be more in the body and fundus of the stomach. Okay. So these gastritis can in turn complicate into a peptic ulcer disease. So repeated episodes, these gastritis can form proper ulcers. These peptic ulcers can either be present in the stomach or the duodenum. Most commonly, it is going to be present in the duodenum. Okay. So what are the causes? So again, the causes which already led to gastritis are also trigger factors for peptic ulcer disease. So drugs like NSAIDs, tobacco, alcohol, even eating spicy food. So spicy food is also a trigger. And other than that, H. pylori infection, the most common one. Okay. So other than that, we also have blood group O. So O blood group patients have also a predilection for developing peptic ulcer disease. Any ulcer, you will have 4 layers when you see it on microscopy. So the very first layer will be the necrotic layer. So necrosis will be there. Then next will be the inflammatory layer. So inflammatory cells will come and eat up, try to clear up this necrotic debris. Then third layer will be the granulation tissue. So repair is trying to form. So granulation tissue will be the third layer. And lastly, we'll have the fibrosis. The fibroblasts present in the granulation tissue will lay down collagen and it will try to complete the scarring. So fibrosis will be there. So the 4 layers of an ulcer will be necrosis, inflammation, granulation tissue and fibrosis. Not just in peptic ulcer, anywhere ulcers, this is the 4 important layers. Now let's see about the 2 types of peptic ulcer disease. So based on the location, they are classified into a gastric ulcer or a duodenal ulcer. So I already mentioned duodenal ulcer is going to be the most common location. So there is difference in the presentation of these ulcers as well. Suppose if the patient is having a stomach gastric ulcer, so the most common location of that will be is in the lesser curvature. So in the lesser curvature, especially near the incisura angularis. So there the patients will be having the gastric ulcer and usually the patients will develop pain during daytime. And then it will be relieved by vomiting. Only when they vomit, they'll be able to relieve the pain. And it has an increased risk of cancer. So increased risk of developing gastric cancer is there. And there is also a very high risk of developing perforation. So this gastric ulcer can perforate. So when it perforates, it is going to cause intra-abdominal peritonitis. Then also there is also increased risk of bleeding, but not as much as the duodenal ulcer. And bleeding will be there because this ulcer can erode into the left gastric artery, which is very close to the lesser curvature. So left gastric artery can be eroded and can cause bleeding also. So in duodenal ulcer, the most common location will be in the first part of the duodenum. So the first 2.5 cm is the D1 part. So the first part of the duodenum is the most common part of developing duodenal ulcer. And here the patient will usually have a night pain, so nocturnal pain. After sleeping, they'll suddenly feel pain, and if they eat food, it will be relieved. Okay, so this pain is going to be relieved by food intake. And here, as such, there is no increased risk of cancer, and the risk of perforation is there, but not as much as in a gastric ulcer. But the risk of bleeding is going to be very high here, and here the duodenal ulcer can erode into the gastric duodenal artery. So GD artery is going to be eroded and there will be massive risk of bleeding. Since this Helicobacter was the main culprit, the most common cause of causing gastric ulcers, most common cause of causing ulcers, gastritis and peptic ulcer disease. So let's see about it. So I already mentioned it is a bacteria. So what kind of bacteria? It is a gram-negative bacillus. So it is going to be lophotrichus, meaning this bacillus is going to have a tuft of flagellae at one pole of the bacteria. So tuft of flagellae is present. So it is a lophotrichus flagellae will be present here, and hence it is also the most common cause of chronic gastritis, as I told. What type? It was type B. So type B, where will it be present? It will be in the antral region. So antral gastritis is going to be there, and here humans are the only host for H. pylori. And I already told it is a non-invasive bacteria, meaning it is not going to invade into the epithelium. It is just going to be present on the luminal surface of the epithelium. And from there, it is going to cause all this trouble. So what are the virulence factors for this pylori? It is going to be the presence of the flagellae, which was the Lophotrichus flagellae. Then it can also produce urease enzyme. Then it has toxins like CAG-A and VAC-A toxins. Apart from that, with the help of adhesins only, it is going to adhere to the epithelium. So microscopically, if you see, there will be lots of lymphoid aggregates seen in the lamina propria. Since it is a chronic inflammation, it is going to have a lymphoid aggregates. So how do you stain for this H. pylori? Usually we get requests for Giemsa stain. So Giemsa stain is the most common stain which we use for staining this H. pylori. So on H. pylori, on Giemsa stain, this kind of small rod-shaped bacillus will be present on the lumen. So this kind of image will be given, and they can ask what bacillus is this. So the most specific stain for staining this H. pylori will be a Warden Starry silver stain. So Warden Starry stain is a silver stain. Here it is going to have any silver stain. I've already mentioned it is produce a black color. Whatever it is detecting, it is giving a black color. So the organisms are going to appear black in color here. And other than that, we also have Steiner stain, which is also a silver based stain. And the most important thing about H. pylori was it is not just, it doesn't stop with causing gastritis and peptic ulcer disease. It has an increased risk of adenocarcinoma of the stomach and also maltoma. So maltoma is a lymphoma. So both maltoma and increased risk of gastric adenocarcinoma is going to be triggered by this H. pylori.